Mm-hmm. Yay!
Hey, perfect.
Technical difficulties, but we did
Awesome.
it.
Yeah, no, thank you. We're just trying to like set ourselves up in such a way that you can see both of us.
All right, there we go. Good to see you again.
Yeah, thank you. You as well.
All right, so, okay. So now people are hopping on here.
Cool.
Awesome. All right,
Okay.
so I guess I'll get started. So for anyone that doesn't know me, my name is Natalie, and I'm a strength and conditioning coach. And I train general population, but I would say I mainly have women clients, um, and that's before pregnancy, during pregnancy, postpartum, and then I have a lot of women premenopause, going through menopause, all that stuff. So, and then there are some times where there are some things it's out of my scope and I can't help them with, and that's why Dr. Bree and Alyssa specialize in the pelvic floor.
Yeah. Yeah, so we can kind of do a quick introduction. So again, I'm Dr. Alyssa.
I'm Dr. Bree.
And we own Renew Health, which is a 100% pelvic floor practice in East Longmeadow, Mass. So we've been practicing clinicians now this is our 8th year, which is kind of wild to think about. We were reflecting on that the other day, and I was like, oh my gosh, how have we been doing this for almost a decade? And we've owned our practice. This is the start of the 3rd year of us owning our private practice, but we've been doing pelvic health for years now.
That's awesome. And then what made you want to specialize in pelvic floor?
Yeah, no, that's a great question. Bree can probably answer
So
that
there's a few things. Well, actually, when we were in PT school, actually our practice was a school project. So in 2015, one of our projects was to break into groups and come up with a business plan to open up a clinic. And, everyone around us was pretty much doing like a sports performance, orthopedic practice. We had just had a 1 hour pelvic health lecture, which is not enough in schools, but that was kind of fresh in our minds. And we came up with a pelvic floor specialty practice and we called it Renew Health. So then fast forward, 9 years ago, fast forward 9 years, and we stuck with the same name, and our practice is again just
exactly what we wanted
it to be 100% pelvic floor, and offering some really awesome services to our community. So that's also like, it's just so cool that we've been able to do this.
I love
it. Really like this type of treatment in Western Mass and like Northern Connecticut.
I love that. And I definitely want to spread the word, because when I first became a personal trainer, we'd be doing group exercise, and, women would run to the bathroom to go pee during class. It happened at least, one person every time. And, we didn't go over pelvic floor that much either. So I always just kind of thought, oh, well, they've had a couple kids, so that's why,
Yeah.
I was like, that's not the case. Everybody needs it sometimes. So we have a bunch of questions from people.
Yeah, I know. We had so many questions.
That's exciting. So,
which is
so hopefully it helps some of the other people watching.
I know. Yeah, absolutely. And Bree and I were kind of joking about this, where we're like, man, all these questions, like we could do 1 billion of these, right? Like,
I know.
There's so much information, but really it starts with the misinformation that's out there surrounding pelvic health, right? There's so much misinformation. And one of the things that we commonly say in our practice is just because it's common doesn't mean it's normal, right? And so the scenario that you had just mentioned of like these women that are like rushing to the bathroom, for example, and it's like, oh, well, you did have a couple kids.
Right.
Common, but it doesn't necessarily equate to it being a normal thing. So yeah, lots of information that we're hoping to at least, brush the surface of today. And again, we'll be able to talk to folks if they have questions, of course, during the live, and then after, we'll make it sure that, folks can find us.
Well, let's start with the first question. What should I look for in a pelvic PT office?
Yeah, so I was like, oh my gosh, I love this question. I saw it and I was like fired up, because that's a great question, right? And like this whole live could be about that question. But really, when you're looking for pelvic floor physical therapy and you have goals surrounding specific problems, the first thing is that they should be a pelvic floor specialty practice. Like that, and that's like our opinion, but seriously, what we see and what we hear and all the things like that really is super important, is that it really should be a pelvic floor specialty practice. So there should be an area within the clinic that like it makes sense that you do pelvic floor therapy there, right? So the biggest thing that we see is like these kind of tacked on like little programs of like the therapist does 99% orthopedic and then they kind of throw in a couple pelvic floor patients on their schedule type of thing. And for us, that just doesn't fly, because it really should be something that folks are so dedicated to this type of care and treatment. So automatically it should really have at least some degree of specialty.
Yeah, we say that like if you're seeing a pelvic floor therapist, like they should be like in love with pelvic health. They're not, and now like we love social media, like we love that, the presence of Instagram and TikTok has really, I think, made our specialty kind of explode, right? But the thing with that is we don't find that pelvic floor is cool or trendy. It's necessary, right? So, we would advise people to make sure that you're going to someone that loves what they do, has the passion for pelvic health and isn't being maybe pressured in a hospital-based system to go to a weekend course and learn a little bit and then call themselves like an expert. You really should be finding someone that really cares about this as a person and has the experience to back it up.
Definitely. And then also just like the environment of the clinic, I think makes a lot of sense, right? Like for us in our clinic, we have several private treatment rooms. So there should be an area that's like dedicated to privacy, in an area where folks coming in with pelvic floor dysfunction can feel safe. So that's super important. And for us, it's like if you have to walk through a really busy gym to have pelvic floor therapy, it might not be the best fit. And like having a curated space where it really feels like not only the clinicians have the expertise to treat the problem and get the result you're looking for, but also like, what the heck does a clinic look like? Does it look like a clinic that can progress folks to functional based movements, but also have that private clinic environment that is helpful for, again, sensitive topics?
Yeah, and if you haven't been down to Renew Health, I've been to their clinic and you feel very comfortable there, which is super important because, at work, like some of my clients will try to be asking me questions about stuff like that. And we're over in the corner and they're kind of like, hey, Natalie, like this is going on. And it's not the place to talk about it. So I'm like, all right, go see them. They'll make you feel comfortable. And
no, that totally makes a lot of sense. And, I worked in a practice that in one of the clinics that I was working in, you have to, Alyssa mentioned, it was like walking through a busy gym setting where, Joe's getting his knee replacement worked on, someone's working, a high school athlete is like grunting with weights, and then we're talking about stress incontinence or pelvic pain. And that doesn't inherently create a safe environment for clients. So it's really important for us to foster that.
Absolutely. Yep. All right, so let's get into like the exciting questions. So some of these questions,
clinical stuff
people,
and like
people like definitely don't want to ask these questions, and I want them to know that other people are going through the same thing, so it's like they're not alone. So the first one I picked out was, I am super active but still leaking. is this common? Not normal, but it's probably common.
Yeah. Yeah, totally.
So you'd be surprised that the incidence of incontinence is very high in active individuals, right? You don't see that quite often with other, conditions, disease processes, things, that oftentimes the more active you are, right, you don't have any of these issues. And it doesn't mean, we work with CrossFitters, we work with power lifters, but we need to, again, make sure that athletes and active individuals are getting a pelvic floor assessment and really working with a trained professional to work on the incontinence piece, because they can do all the strength work, that they're doing at the gym, but that doesn't equate to not having any sort of leakage problem.
Mm-hmm.
Yeah. And so for us, what we tend to see more often in our clinic is not a patient that comes in with like a weak pelvic floor.
Mm-hmm.
So there's this, again, I think anybody that knows of like pelvic floor therapy, they probably think of the word Kegel, right?
Yes.
And I'm actually surprised. I don't know if that was an exact question,
It's
but that's
on here. Yep.
okay. Yes. Okay. So yeah, it was. Okay. Thank you. Where again, it's like pelvic floor therapy equals Kegel. If I leak when I exercise or sneeze or cough, I should Kegel. If I have pain, I should Kegel.
Mm-hmm.
But really, that's part of the problem. That's part of the problem is that without a pelvic floor evaluation, and we can kind of dive into that a little bit too, of like what it looks like to have one. We don't know what's going on with the pelvic floor. We might know based on signs and symptoms, and kind of we can, parse out different things and kind of put people into different categories and kind of understand from just a good subjective. But for folks that are just doing activity or super active and they love what they're doing, and maybe they think it's like kind of protective to the pelvic
Mm-hmm.
floor, if they have a pelvic floor that isn't functioning well, it might not be the only thing that they need to do as far as exercise or even a Kegel. So what we tend to find more often in our clinic is folks that are really, really active. They tend to have issues with like pressure management, or they have issues with having a pelvic floor that is too tight. So the muscles in the pelvic floor are not necessarily just weak. They have a degree of like hypertonicity or tension, is another word for that. And that's determined and really diagnosed through a good subjective history and doing a pelvic floor evaluation with a trained pelvic floor physical or occupational therapist.
Mm-hmm. Yeah, it's similar to, all the misinformation out there. Like, I'll have clients come in and they're like, hey, I saw this on Instagram. Should we do it? And I'm like,
Right.
there's just so much out there. And that's how it's been with Kegels.
Right.
Like, just do your Kegels. But you've never actually seen someone for it. Same with like some of the workouts that are on Instagram. It's like, that's not for everyone to do.
Right, exactly. And then even when we think about just Kegels in general, it's like that word could mean so many different things to different people, right? And if you go to your provider, let's say, it's an OBGYN or a PCP, whatever, whoever it may be, and they're like, oh, you're leaking, do Kegels. Most often, patients are not even going to know what you're talking about. They might have an idea, but they might not even be accurate in like what it actually is. And then it comes to like, also, how many are you doing a day, right? Doing 2 Kegels a day is certainly different than doing, 300 a day, right? So they just tell you to do this arbitrary exercise, and then you don't have any more information outside of that.
Right.
And for you, like, it's easy to show somebody how to do like a bicep curl, right? Because it's like, here's the bicep, here's the motion. If I said, hey, I'm doing a Kegel right now, you'd be like, okay, I didn't even know that, right? Like, you can't see it. They're muscles that you can't see. They're muscles that inherently we're not familiar with, right? And so it can be very difficult from just like a brain muscle connection to even figure out what a pelvic floor contraction is versus a pelvic floor relaxation. And so most people actually do Kegels wrong, even if that was something that would be helpful for them. It's usually performed incorrectly. But like Bree said, to kind of circle back around a little bit, most of the patients that we see are active, and a lot of them are struggling with leakage, coughing, sneezing, jumping, running, things of that nature. And so definitely something that is super, super common, but something that can absolutely be worked on. And it can be worked on at any point in time, right?
Mm-hmm.
We don't see the people generally that are like calling our clinic and saying, hey, I've been leaking for like 3 weeks. Can you help me? No, it's like, I've been leaking for 10 years.
Aw.
I've been leaking for 15 years. And so a lot of times folks kind of get used to that as being a problem. And so instead of exposing the type of activity that they want to do, they just avoid, right? They're like, oh, well, you might ask a client like, are you leaking with jumping? And they're like, well, no. And I'm like, and they're like, well, because I don't jump, right? So I can't leak.
Right.
So we don't like that avoidance, right? We want to expose folks to that in a specific graded way.
Yep. Which, speaking of sneezing, I think we have one of those questions. Does blowing your nose or sneezing, coughing mess up your pelvic floor?
So that question, again, inherently, if we sneeze and cough, like the majority of us, if we're not prone to any sort of like pelvic floor dysfunction, we're going to be totally fine, right? The problem that we see is conditions where you might be susceptible for some pelvic floor issues, maybe a pelvic organ prolapse, where essentially the organs are kind of, they're shifted, they're not in their normal anatomical position. A lot of patients, usually with a prolapse, might have pressure management issues. So inherently, if we can't control our intra-abdominal pressure, so the pressure within we call it our core canister, if we don't kind of manage that pressure well, then coughing, sneezing, any sort of straining, right? Even like pooping, right? We hear a lot in our practice, individuals that are really like bearing down, straining, even with lifting, that can be a thing. So inherently, like sneezing, blowing our nose is not problematic, but it could be for people that have a pressure management issue in their bearing down.
And definitely, like, just to kind of piggyback what Bree said a little bit, like blowing your nose on the toilet.
Yeah, that's
right. Like we don't necessarily advise that, right? Because you're sitting on the toilet, and again, let's say you've been sitting there for a little while too, and you go to blow your nose, like that pressure is going somewhere, and it's usually going down. And so again, for folks that are maybe struggling with some incontinence symptoms or some pelvic heaviness from a prolapse, we don't necessarily advise blowing your nose on the toilet, for example.
And you shouldn't strain while urinating either, right?
Correct. Right.
You're supposed to be relaxed.
Our peers, right? Yeah, like, and again, a lot of our folks too, it's like healthcare workers, right? Or like folks for busy schedules, teachers, like, well, I only have like a few minutes in between like my class or my patient or my next client, in your case maybe, right? And so they're like, I'm gonna go pee as fast as I possibly can. And they sit down on the toilet and they push. That's not necessarily a good like habit to get into with regard to the pelvic floor, because the pelvic floor should really relax for a few things. For peeing, for pooping, and then for delivering a baby, right? We need a pelvic floor that can kind of get out of the way and relax for us. And so if we're creating tension in those muscles, it can, again, potentially lead to some implications with the pelvic floor.
Guilty. I've done it in between clients.
I remember,
but then it's like, but you don't, I feel like when I would do that though, like I wouldn't completely go, like finish.
Relax, yeah.
So I'm like,
so that's what we call incomplete emptying, right?
Yeah.
There's lots of little muscles around the pelvic floor that are surrounding like the urethra as well. And so again, if we're creating tension around the urethra, even though it should be relaxing, now we might just pee a little bit. We might have like a couple trickles or something, right? And then all of a sudden we're like, well, what the heck? I feel this pressure. I have to pee. But because we're pushing and creating tension surrounding the muscles, we might notice some incomplete emptying.
So not productive. So take your time, everyone.
Right? A lot of people hover over the toilet, especially if they're fearful of going to the bathroom in public. So that's something that can also create a lot of pelvic floor tension and can lead to incomplete bladder emptying as well.
Yeah.
So sit on the toilet.
Like just like put some like toilet paper in the public,
creative.
Yeah.
Make a little barrier.
Right. Okay, let's see. And then we have quite a few questions on diastasis recti.
Okay. We kind of figured there'd be lots of questions surrounding DR.
Yeah. And I think right now I have 2 clients that are pregnant and one that's postpartum. So this comes up a lot for me. Um, so let's do the first one. The best exercises to prevent it, and then the best exercises to recover from it.
Okay.
Mike, and that's situational too.
Yeah.
It depends. It's the answer that we all hated in grad school, right? Where we're like, but give us the answer. It depends. Really, there are no, and you can Google this, right? Like, you know, you might have a diastasis recti and you hop on Google and you're like, what are the best 6 exercises for DR?
Yeah.
You're going to have like these programs that probably just, you know, again, are costing you some money every month or whatever. Like, and it's saying that like these are going to cure your DR or whatever. But really it depends on the patient, right? So, or on the clients or whoever it is that is seeking out this information. Diastasis recti is 100% common and 100% normal in pregnancy. Okay, so that's kind of the exception to our little rule where because of baby, again, the abdominal wall is going to separate and it needs to separate, right?
Mm-hmm.
So the things that we look for in pregnancy are like doming and coning, right? And so I don't know if you're super familiar, if you've seen that in your clients that are pregnant, where like the abdominal wall will kind of like pop out a little bit, or you get like that little bit of protrusion. Sometimes it can be more of like an invagination where it kind of comes in.
Yeah.
Definitely more so postpartum. So we look at that. And really the goal is to be able to perform exercises with good pressure management. So how are we breathing? What is our pelvic floor doing? How are we breathing and bracing our abdominals, right? And then looking at the load of that activity.
Yeah, so kind of just piggybacking on that as well. With a DR too, I think a lot of people get very concerned with the width of a separation. But as far as like getting really seeing how the abdominals are functioning, we check the depth of the separation. So again, there's a lot of information about, oh, like the wider the gap, the worse that things are. That's not necessarily true. We really want people to have a well-functioning core. And like what Alyssa said too, is as far as, you know, you can Google DR do's and don'ts. And so don't listen to any provider that honestly tells you to stop doing things, right? You know, they'll tell you to stop doing planks. Don't ever do crunches again. Don't ever sometimes, you know, do heavy lifting again. And a lot of that is just misinformation, right? Especially think of a postpartum mom that just had a baby. They have maybe some abdominal wall separation. They're told not to lift anything, but then they're being handed over a newborn. Like, how much sense does that make, right?
Yeah.
So I think there's a huge shift with diastasis recti treatment where we're really we really want to get the message across that people shouldn't be scared to do things. Right? Or they don't need their abs to fire correctly or exactly the way that they think that they're supposed to in order to progress.
Yeah.
People that continue to have some abdominal wall weakness or some separation usually don't progress enough. They don't load enough, right? So personal training, like, you know that you have to progressively overload, right, to make changes. If you're still doing the same you know, I don't know, pelvic tilt on the floor for 8 weeks in a DR program because your abs aren't firing correctly, then you're missing the boat.
Yeah, you're not going to get that progress that you want. Yeah. And then I mentioned like doming and coning, and I think that's another thing too where there's a lot of misinformation about it, where you might have like a little bit of doming and then folks are like, oh, well, I saw my abdominals kind of like protrude a little bit, I'm just going to stop. And doming and coning is not always bad either. So there's a way that we evaluate it, and there is more acceptable doming and coning, and then there's doming and coning that we see that shows us that there's just too much load through the system, or the pressure is not being managed well through the system, and so that's when we start to make modifications in how somebody may be moving. So like a plank for, you know, pregnant patient A might be totally fine. They might be like killing that plank and doing so well and have no doming, no coning, no symptoms, no leakage, no pain. And then patient B at the same exact, you know, week of pregnancy might be symptomatic, right? So we just have to be specific to the person in front of us and really look at symptoms as a way to guide versus, Googling something or being fearful of movement.
Mm-hmm. Definitely the women I have before they get pregnant, and they're strong beforehand. And then of course we do things like while they're pregnant. The people, when they are working out pregnant, there are people that kind of say things to them like, "Oh, you're still going to the gym?" And my clients are like, "Yeah, like I was going beforehand. My doctor says I can. I still feel good, and like I want to get ready for postpartum." And there's still that, like don't lift anything while you're pregnant.
Yeah. And there's a lot of research now, again, that is not a congruent statement. Like we know that exercise is absolutely safe and recommended, right, during pregnancy. But yeah, I can definitely see where like you might see that a lot, right? Or you might see folks that are maybe 50s, 60s that are a little bit older that are looking at younger folks that are like, oh, well, I never did that during my pregnancy. So maybe there's like generational gap too of what women are being told now to do versus what old recommendations were.
Yeah. Yep. Let's see, we got more diastasis recti. Here's one. Can your DR get worse after you rehab it?
I would say short answer, like maybe, right? It depends. Again, it depends. There's a lot of other factors that go into diastasis recti and maybe the appearance of your stomach even. So I would say on one end, if you're not progressively loading, then you might not see the continued improvements, right? So if you did some, and again, it depends on what the rehab looked like, right? But if you went to a physical therapist and they saw you twice a week for 4 weeks, and then you're like, I rehabbed my DR, but then it's kind of still there. Well, you didn't give your system and your body a chance to progressively overload, right? So again, DR, and that's why, a lot of these clinics that kind of work with individuals with DR, if they're seeing you for a month or you're doing a 6-week program, that's not enough to progressively overload, right? You need changes over time. So that's one part of the I guess picture, right? And then also a lot of our patients that might have fluctuations of what their abdominal wall looks like too is, I would ask about bloating, right? So GI function we would definitely take a look at as well. So sometimes bloating can lead to more of an appearance of maybe some lower belly pooching, or some people might say that their diastasis recti looks different, so based on like GI complaints. Another thing too is just making sure that the abdominals are working kind of, again, all in sync, right? A lot of times what we see in individuals is that they have weaker lower abdominals and they might have overactive obliques. And that can create this almost like a squeezing effect, right? You think of like a tube of toothpaste, you squeeze it, toothpaste is going to come out. So if they are very oblique dominant and they're creating this decreased pressure, pressure downward, sometimes that can lead to that lower belly pooch that everyone wants to get rid of, right? They've tried all the diets in the world, they've done all the core strengthening, but sometimes that can also be, again, a lower abdominal strength issue. It could be a pressure management issue. It could also be a pelvic floor tightness issue as well. So for that person that thinks maybe, is it coming back? I did some rehab. I would address digestive health. I would look at the core exercises and other just exercise in general, what they're doing. Are they doing anything for the lower abs? Do they feel everything upper? And then I would definitely make sure that they have an internal pelvic floor assessment as well.
Yeah, I can see that. People doing their 6 weeks and then they're like, all right, I'm done. I did my 6 weeks. So, but it's just like extra, like coming to the gym. I'm like, we're doing this for life. It's not just an 8-week, course.
Yeah, absolutely. And also to kind of address as well, like if somebody has multiple pregnancies, for example, right? One question that we'll get a lot of is like, should I bother? Like, should I put the time and effort and all this to quote unquote rehab my DR if I plan on having another baby?
Mm-hmm.
It's always yes, because we want the most function out of the core. And the core is the diaphragm, the pelvic floor, the abdominals, and the back. So we want the most optimal core anyways, right? And so then if there is more of a diastasis recti that occurs with subsequent pregnancies, you already know kind of what to do, right? Not to say that every rehab process is going to look exactly the same, or that every pregnancy and delivery is going to look exactly the same, but you have a lot more of a foundation as to what do I do with my next postpartum period.
Mm-hmm. And speaking of postpartum, when can you return to certain exercises, which of course is going to be case by case?
Totally.
Yeah.
Generally.
Yeah. And again, like this is like for educational purposes, of course, this is not meant to be a platform for medical advice, right? So we always, I feel like making that disclaimer, right? But again, typically folks that are postpartum, they have their 6 week, typically around 6 week medical appointment where they check in with their physician or midwife, right? And typically at that point, if they have no complications, then they get a medical clearance to return to exercise and other activities, right? So that's a pretty common one, right? However, what we do as pelvic floor physical therapists is different than a typical medical exam, right? So they're looking for infection, they're looking for healing, they're talking about potentially like birth control options, things of that nature. Whereas what we do around that time frame is what's going on with the pelvic floor? How is it functioning? And so we always use, again, symptom like as really the guide to returning to exercise specifically. Now, if folks are really active during their pregnancy and are maybe running throughout their pregnancy or doing CrossFit throughout their pregnancy, maybe they've worked with us already and have done birth preparation and things of that nature, they might be able to do things once they get the medical clearance, of course, they might be able to do things a little bit quicker. But the thing that we always mention too, to our folks that we're seeing, is try not to compare your journey with other people's journeys, because you might see your best friend go for a 2-mile run at 12 weeks postpartum, but you don't know if they have leakage. You don't know if they had pain after. You don't know if they have a prolapse, right? So definitely we want to stay away from comparisons, right? Because everybody's journey is different. But once we see folks after that medical clearance, we're doing a pelvic floor assessment. And then based on that assessment, then we're like, all right, let's do it. What's your goal? Right? And we want to get them back to whatever their goal is specifically. So we're working on return to run screens around 10 to 12 weeks postpartum, again, depending on our patient. And we're really looking at what their function is.
I do want to add to that, again, Alyssa mentioned like that 6 week kind of clearance or to be able to return to heavier, activities. Keeping in mind that, when we see patients during pregnancy and we're, again, following up with them postpartum, certainly there's a lot of things that you can do before the 6 week time frame, as far as reestablishing a good connection between your diaphragm and your pelvic floor. So we definitely will give individuals some exercises before the 6 week, as far as like breathing, connection breath, maybe some mobility work, thoracic mobility, mid-back, talking to them about posture, even how to hold the baby properly. And, so we are giving people a lot of information so that they even feel prepared for when they have the baby, especially for like our first time moms too. Yeah. And then, like I said, Alyssa mentioned, as far as like, doing a return to run screen, and a lot of the research shows that waiting until 10 to 12 weeks postpartum for like higher impact activity. And, we do a whole evidence-based like screen in our practice where we're looking at load. Can they jog in place? Can they do single leg activities? Can they jump without heaviness, pressure, leakage, pain, all the things? We are kind of pushing them a little bit to see where their baseline is. And then we kind of get them back to, again, running, CrossFit, the trampoline park, whatever it may be. We have a trampoline in our office. We do. So we can check jumping. But again, the functional activities are really important for us to be able to just get our patients back to. So whatever their goal is what our goals are for them.
And something that we say a lot too is like kind of like 9 months in, 9 months out type of scenario too, where again, folks want to like, they kind of expect that they're going to have that pre-baby strength or body or what or posture, even like anything, and we're like, it takes time, right? And so we would much rather put in the hard work to progressively load up our patients and get them ready from a pelvic floor and core perspective and a mental perspective as well. I mean, we're supporting our patients through that journey postpartum, and we want them to get back to those higher level activities when it makes sense for them specifically. And again, that timeline could look very different for everyone.
Mm-hmm. Do people, when they go see the doctor, are they referred to pelvic floor PT after a baby? Because I brought it up to people before, like, oh, are you seeing a pelvic floor therapist? And they looked at me like I had 5 heads. They're like, no.
That's a great question.
It depends. You know, there are some rock star providers that send patients immediately to us, or just pelvic floor therapists in general, which is amazing. You know, in a perfect world, we would see every pregnant patient and postpartum patient, without question. I did have a client this morning actually that she's like, why did I have to ask my provider 6 times for a referral? And we don't require a referral in our practice because we have what's called direct access in Massachusetts. So we don't need a physician's referral. However, you know, I think she was maybe unaware of that, you know, the direct access laws, you know, but she had to ask and ask and ask and ask.
And I would say that's probably more common when folks are like talking to their providers about pelvic floor therapy is usually they're not making those recommendations truthfully the way that we feel like they should. And for most problems, I mean, for most conditions, healthcare related, it's like, when is it better to wait? Like
the wait and see approach.
Yeah, like the wait and see approach doesn't often work for most things, right? For most things that are pretty concerning, and for most things that we know just don't get better over time without intervention. And there's research that shows that if you are having leakage during pregnancy, the chances of having leakage afterwards are higher. There's research that shows that if you are, 6 months postpartum and you're still having leakage, then the chance of your leakage just spontaneously reducing or disappearing, right, and resolving is not as high, right? So we know that. And so that's why Bri and I have been just really pushing out this education about pelvic health care in general. And our famous words is that we'll talk about pelvic floor stuff to anybody that will listen. And our patients do the same thing.
Oh, good. Which, speaking of your patients, I know you have to get back to them today. But thank you so much for doing this. Just spread the word. And then now we can tell everyone that we're going to do a workshop together.
Yes, I'm so excited for that. So for any other additional questions, because there's, so many that we, again, in a perfect world, we'd have the whole afternoon to be able to get through these. But we will be doing a workshop. And then, Bri and I will likely hop on some lives too to finish out those questions as well, just for folks that, again, if we hadn't gotten to any of them, we'd be happy to hop on a live as well at some point during like the next week or something, just to answer some more of those questions. And then folks can always reach out to us as well. Our website is www.renewhealthllc.com, or of course just shoot us a message, and we'd be happy to connect with folks that have any additional questions.
Yeah, there might be 2 or 3 we didn't get to.
Oh yeah. I just wanted to mention too that if you hop on our site, we do discovery calls with everyone that might be a client of ours, just because we want to make sure that not only are you a great fit for our practice, but we're also the right people to help your problem as well. So we hop on the phone, it's usually 15, 20 minutes where you get to actually talk to a provider, which is so rare these days. So that is something that, anyone can really take advantage of, just to be able to schedule a phone call so that you can talk to, a provider about any concerns that you might have.
Yep. And I think we decided on March 3rd for our workshop. So I'm going to teach a bar class, and then we'll do like a pelvic floor seminar afterwards. So anyone who has more questions so
super excited.
We'll post more information on that, but that'll be fun.
Yeah.
I can't wait. We love doing workshops in the community. We love hanging out with people like you, because it's just so cool. And a lot of what we do just like overlaps. And so, again, being able to hang out and have a joint, workshop. And again, there's so much information that, again, any folks that are really interested in coming, I mean, you're going to learn so much, and actionable things too, right? Actionable things that you can take away from the workshop that you can take home and start working on.
Yep.
Tons of value.
So that'll be fun. I think we're better together.
Honestly, absolutely.
Yeah, absolutely.
Yep.
Thank you for inviting us.
Did anyone type in any questions? Let's see.
I don't know, because we do have a few minutes where we can actually address them.
Actually, yeah.
I don't know. Does anybody?
We can do one more.
Yeah, I was going to say, does anybody have any questions on anything that we have talked about?
I got a good one, because actually someone was talking to me yesterday. She fell while skiing, so this question kind of goes along with it. Tailbone pain management.
Yeah.
Fell a year ago and still in pain. Can pelvic floor PT help with this?
Yes. And I think we do have a couple minutes, so we can absolutely address that.
So the pelvic floor.
We're gonna break out the model here.
Oh yeah, I love the visuals.
With tailbone pain, right? So you can see how the pelvic floor muscles attach right to the tailbone, right? So what we say in our practice too with tailbone management, like what we see is people are going to, they've been to 4 other physical therapists, they've been to the chiropractor, they've been to massage therapists, acupuncture, you name it, and they're still dealing with tailbone pain. If you haven't had an internal assessment done of these pelvic floor muscles, then I would say confidently that people are kind of guessing as to what's going on, because of the attachment point of all these muscles that go right to the tailbone. So we've seen patients, we love treating tailbone pain.
Yeah, we get like really like amped about it, actually.
Because we see people that have had tailbone pain for 5-10 years, and as soon as we do an internal assessment, most often they have hypertonicity. What Alyssa was talking about before is a pelvic floor that's too tight. We do some internal release work. We teach them, breathing mechanics. We work on tailbone mobilizations that we can actually perform internally and externally. We've had patients that are like, wow, this is the first time that my tailbone hasn't hurt in anywhere between usually 5 to 10 years.
Yeah, and the thing about tailbone pain too that I think is super important to note is that, and honestly, you might see this too with the clients that you work with, where they might have been like, well, I think I might have sprained my ankle when I was like 10. Is that why my ankle kind of hurts every once in a while? And the answer is usually no, for the most part, right? It's probably something more acute that's going on potentially, right? But with tailbone pain, I mean, if we've had a patient that has had birth trauma or something, or has fallen on a tailbone, maybe they fractured their tailbone during delivery or fractured their tailbone from falling on their tailbone, it is highly correlated with this prolonged pain, where that incident probably was part of the problem or is part of the current problem. So that's something that we always say, if you've ever had any trauma to your tailbone, you really should see a pelvic floor physical therapist, because they're going to be the ones that can accurately diagnose and treat it. Whereas it's kind of like symptom chasing or kind of guessing as to what's going on with the tailbone. And then again, there's lots of, nerves and all that too that surround that area. The lumbar spine's right there, the sacrum and the tailbone, they all work together. And so seeing somebody that can really, again, kind of parse out, is this a lumbar spine issue versus a true tailbone issue, is really helpful as well.
Yeah, and I think that people, they're in pain for so many years that they just think, they get used to it and they're like, oh, it's normal, that's fine. And I think the phrase no pain, no gain, I've been trying so hard to get rid of that the last couple of years, because doing an exercise, there's pain somewhere, and they're like, it's fine, no pain, no gain. I'm like, no, we're not going to work through that kind of pain.
Right.
Lactic acid, that's one thing, but you got to shift that mentality.
Yeah, absolutely. I think the one thing that we see in our practice too, when it comes to pain in general, not even just pelvic pain, but even hip pain, back pain, is people don't ever really get a good understanding of what's going on. We see ton of people in our patient that have seen everyone else for like, low back pain, for example, because they've never had a good understanding of what's actually happening, what maybe are some mechanical stressors, or, we make it make sense for them, not only just our pain patients, but all of our patients, right? Like, we are really making that a priority, that they know exactly what's going on and they're given the tools to, again, get better and not guess as to what's going on. People want to, they throw everything at the wall hoping that something sticks, right? Especially with low back pain, right? It's like, oh, I did PT for a little bit. I went to this yoga class hoping that would help. I did this, I did that. And a lot of times it's because people don't have a good understanding of why they have pain.
Yeah. Or there's I call it the Amazon Prime body. They just want it like, I'm like, things take work. You have to be consistent and it will get better.
Totally. Yeah.
But
No, a lot of sense. And again, having a good proper eval. And again, with back pain, there's such a high correlation. There's recent research that showed that in this study of women specifically, those with, again, a female pelvis, they looked at those with like persistent low back pain, and 95% of them had a related pelvic floor dysfunction. And so if we're not looking at the pelvic floor and evaluating it properly with folks that have back pain, then we're definitely missing the boat with regard to treatment. And back, again, sacral area, people will say like the SI joint area, right? And tailbone, it all kind of falls into that piece.
Yeah, I hear that one a lot, the SI joint one.
Probably the pelvic floor.
Yep. Like, I know where you can go.
Right.
But again, thank you so much for taking time out of your busy day to come on here.
Yeah. Awesome.
Yeah, and then again, more information to come regarding more collaborations in the future.
Yeah, we're looking forward to it.
Awesome. And I'm going to post this. I'm going to post the long video on YouTube for people that missed it. And yeah, we'll do it again.
Awesome.
Yeah,
yes,
absolutely.
we will. Thank you.
Thank you.
Thank you.
Bye.
Bye.